Video, let us discuss in detail of Apla syndrome. So what is Apla syndrome? Actually, the antibodies are synthesized against phospholipids. So in this syndrome, actually Apla means anti-phospholipid antibody syndrome. That means the antibodies are formed against phospholipids. Okay, against phospholipids the antibodies are formed. The lupus anticoagulant is a misnomer as they lead to thrombosis. Very important. In the name here you can see lupus anticoagulant, as actually it is as we discussed in previous video, it is a most common antibody which is formed by especially in Apla syndrome, lupus anticoagulant. It's a misnomer because here in the name you can see anticoagulant, but it is not a anticoagulant. It's actually a leading to thrombosis. It is leading to thrombosis, like it is leading to arterial thrombosis, venous thrombosis, placental thrombosis. Thrombosis like a clot like structure is formed because of this lupus anticoagulant, which is formed mainly in Apla syndrome. So Apla syndrome is where antibodies are formed against phospholipids. Now coming to Apla syndrome, which can lead to abortion. Actually our main topic is abortion, right? So this Apla syndrome is leading to abortion. Why? And also it is leading to intrauterine death. So one thing you need to remember, Apla syndrome, if it is less than 20 weeks, then it is leading to abortion. Greater than 20 weeks, it is leading to intrauterine death. And after like about near to gestation, like above 24 weeks or 30 weeks, it is leading to stillbirth. Okay, so now combined as fetal death by causing placental thrombosis. So now this is combined, the stillbirth is combined as fetal death by causing placental thrombosis. Okay, so intrauterine growth retardation is caused when the thrombosis does not completely cut off the blood supply. Actually, intrauterine growth retardation is occurring when thrombosis is not completely cutting off the blood supply. Okay, so Apla syndrome also has a risk of causing PIH. Apla also have a risk of causing PIH, that is pregnancy induced hypertension, because it is like somewhat cutting off the blood flow from the placenta to the fetus, and also like to the mother. It will lead to pregnancy induced hypertension. So how to diagnose this Apla syndrome? Diagnosis is you use modified Saporo criteria. That is the first lab criteria plus first clinical criteria. Okay, so it is having one lab criteria, one clinical criteria. Okay, so now let us see what is this clinical criteria. One clinical criteria is arterial or venous thrombosis and 3 or more than pregnancy loss occurring at less than 10 weeks. Okay, and one pregnancy loss occurring more than 10 weeks, like in second trimester, which is more specific. Okay, one or more preterm delivery occurring due to uteroplacental insufficiency or PIH. Okay, so these things we need to remember. Now coming to lab criteria. So in lab criteria you have presence of any one of the three antibodies, either may be anticardiolipin antibody or anti-beta 2 glycoprotein antibody or lupus anticoagulant. Okay, on two occasions and 12 weeks apart. This is the criteria. And next coming to management. So how to manage this Apla syndrome? You should give heparin plus aspirin. Give heparin and aspirin together for patients of Apla with history of abortion or either thrombosis. Heparin is given only after confirming intrauterine pregnancy. Okay. Next coming to the patient of Apla with no history of abortion or thrombosis, but with the history of one preterm labor due to PIH with presence of antibodies, then give just aspirin. So this is a criteria you should see. In the first case, a patient with history. Already in her history she is having abortion, thrombosis. So for her you will give combination of heparin aspirin. But coming to this patient, no history of any abortion or thrombosis in the previous, but only one preterm labor. So just give aspirin for her. Now coming to Apla in a non-pregnant female. So in a non-pregnant female, in Apla you'll give just warfarin. Okay, in pregnant female we should not give warfarin because it will cross the placenta, right, and it will lead to warfarin embryopathy. So because of that warfarin embryopathy danger, we will not give this warfarin in a pregnant female. So warfarin embryopathy is closely resembling to chondrodysplasia. Okay, and these patients have stippled epiphyses. In warfarin embryopathy there will be stippled epiphyses, which you need to remember. Next, coming to warfarin. Warfarin is avoided during pregnancy, especially in first trimester. Remember, especially you should avoid in first trimester in pregnant female. In non-pregnant female you can give whenever you want. Now coming to cervical incompetence. So some, as we discussed, the reasons of abortions, especially for recurrence abortions, the second most cause is cervical incompetence. So the most common cause of second trimester recurrent pregnancy. So mainly it is seen during second trimester. For this, the clinical criteria is the patient have painless dilation. There's painless dilation of os. You know, in the cervix you have os, right? So painless, that is important. There's no pain here. Painless dilation of os causing rupture of membrane and expulsion of fetus. So fetus is coming out. Two or more consequent loss of pregnancy in the second trimester may be seen. Okay, and patients with cervical incompetence can have preterm labor more frequently. So they have a chance of preterm labor more frequently. And next, as the number of pregnancy losses increase, the gestational age at which the loss occurs decrease. So what does it mean? For example, if this patient is having three abortions, right? So for a fourth abortion, actually what happens, for example, in the first abortion the number of pregnancy losses increase. The gestational age with, for example, first abortion is in 24 week, for example, second abortion is in 20 weeks, third abortion will be in 18 weeks, and the fourth one will be in 12 weeks. So you can see the number of gestational age is dropping as the number of pregnancy loss is increasing. Okay, now coming to note, in cyphals you need to see one note. In cyphals there is one law called as Kassovitz law. As the pregnancy loses increasing, the gestational age at which loss occurs will also increase. So here both the gestational age and pregnancy loss are increasing. So for example, first abortion is in 20 weeks, second abortion will be in 24 weeks, third abortion will be in 30 weeks. You can see the number is increasing. So it is reverse in case of cyphals, but in cervical incompetence the abortion is decreasing, the number age is decreasing. This you need to observe. Now coming to diagnosis. So in diagnosis of cervical incompetence in a pregnant and non-pregnant female. In non-pregnant female, you need to see there are two or more consecutive loss of pregnancy, especially in second trimester. Then you need to pass an Hagar dilator number 8. Hagar dilator is just like this pen. For example, you will dilate the os there. Okay, Hagar dilator, especially number 8. All Hagar dilators are an even number, so take number 8. If it passes through without resistance, then internal os dilated. Okay, now coming to hysterocervicography. What is this? The dye passes through the internal os and reaches the cervix and forms like a funnel shape. So like this funnel shape. Okay, now coming to pregnant. This is all seen in non-pregnant female. Means in a non-pregnant female, if you pass a Hagar dilator, it will pass through it without any resistance and the os will get dilated, and in hysterocervicopathy you will see a funnel shape. Now in the pregnant female, let us see what is going to happen. In a pregnant female, two or more consecutive loss of pregnancy in second trimester. The history of one second trimester loss is present. Do ultrasound. Measure the cervical length. If it is normal like 4 centimeters, then if the length of the cervix is less than or equal to 2.5, internal os is more than or equal to 2 centimeter dilated. Internal os is dilated, but the cervix length is decreased. So now here what happened, the management is you need to do cervical cartilage. Cervical cartilage is done only in pregnant females if clinical criteria are fulfilled or there is having any history of second trimester loss. So mainly in second trimester loss you will do this, or history of preterm labor in previous pregnancy. USG is done, and if criteria is fulfilled then cartilage is done. So always do USG, after that only go for this process to confirm. Okay, on routine USG where cervical length is less than 2.5 and if there is no previous history of second trimester abortion or preterm labor, you say it as an incidental finding, then also cartilage is not provided. They are administered with progesterone to prevent preterm labor. So this is very important. Just give progesterone if you find the cervix is dilated incidentally. Okay, incidentally, but if you see it wantedly because you are seeing there's a problem, then you should do cartilage. Okay, emergency cartilage or rescue cartilage. What is this? Emergency. In this case, the patient with the pain is in pain on examination found to have dilated cervix, which is less than 4 centimeters and the membranes are intact. So you can see it's a very emergency case because now the cervix has dilated less than 4 centimeters, right? So this is very important. Now let us discuss about cartilage. So cartilage is actually of two types. Okay, one is McDonald cartilage, one is Shirodkar cartilage. So McDonald cartilage is the most common, like McDonald's. Okay, and the purse string like structure, actually it's a purse string like structure. Next, coming to cartilage, Shirodkar cartilage. Okay, the cartilage is usually done between 12 to 14 weeks. Okay, especially at 14 weeks it's better to do. Should not be done beyond 28 weeks as it may cause rupture of membrane. So always remember, greater than 28 weeks don't do cartilage because it will lead to rupture of membranes. And it can be done till 24 weeks of gestation. Better to do till 24 weeks of gestation. Between 24 to 28 weeks it is individualized. It is according to your opinion, according to the case you can do. Okay, the stitch, this cartilage is like a stitch, so you need to remove the stitch, right? So you will remove the stitch by 37 weeks. If not removed, then it may lead to uterine rupture during labor. So we need to remove it because we want to deliver the baby right after 37 weeks. If you will not remove, what happens? There is uterine rupture during labor because there's no cervical opening if baby can't come if there are sutures. So contraindications and what type we need to give this cartilage. Contraindications for cartilage are dilation is more than equal to greater than 4 centimeters. If the cervix is greater than 4 centimeters, even though you do cartilage, the cervix will not become thin. Next, coming to ruptured membrane. If already the membranes are ruptured, then don't do cartilage. And if there is any presence of pelvic infection, then don't do cartilage because that infection may now attack on this also and it will aggravate. And any presence of grave congenital anomaly in fetus. So if there is any anomaly, congenital anomaly in fetus, no need to do cartilage because already fetus is having anomaly. Now why to do this cartilage? Okay, so next we'll start with types of abortions in another video.